A 65-year-old male presented with progressive dyspnea and weight loss. I am showing you his thoracic CT scan. Describe the findings.
Hmm. Okay. The CT image of the thorax demonstrates diffuse, irregular, and nodular pleural thickening in the left hemithorax. This thickening measures upwards of 1 centimeter and also involves the mediastinal pleura. No focal intraparenchymal pulmonary abnormality is seen, and there is no visible mediastinal mass.
Excellent. What is your primary diagnosis?
Given the progressive dyspnea, weight loss, and characteristic pleural thickening, the primary diagnosis is malignant mesothelioma.
What are the key differentials for diffuse pleural thickening?
In that case, the key differentials for diffuse pleural thickening include malignant mesothelioma and pleural metastases, usually from an adenocarcinoma primary such as breast or lung. Other causes to consider are empyema and pleural fibrosis, resulting from prior infections such as tuberculosis or fungal disease.
How does mediastinal pleural involvement help in the diagnosis, and what is the typical etiology of this condition?
Well, pleural thickening involving the mediastinal pleura is a very strong sign, favoring malignant mesothelioma over benign causes. The etiology is strongly associated with asbestos exposure, with a latent period of up to 45 years. Approximately 5 to 10% of asbestos workers will develop mesothelioma.
Let's look at another slice. I'm showing you axial CT images of the chest. What classic findings are demonstrated here, and what is their clinical significance?
Okay, as seen in this axial CT image, this chest CT scan, which shows bilateral anterior calcified pleural plaques, the findings are characteristic of previous asbestos exposure. When identified, we must examine the CT closely for features of asbestosis, which has significant implications for patient morbidity and financial compensation.
How does mesothelioma typically spread, and why is there often no mediastinal shift despite a large tumor volume or effusion?
Mesothelioma typically involves the parietal pleura and spreads locally to the chest wall, mediastinum, diaphragm, and peritoneum. It also spreads lymphatically to hilar and mediastinal nodes and hematogenously to lungs, liver, and adrenals. Unilateral pleural effusion is common, but does not cause mediastinal shift because the tumor encases the lung, creating a fixed or frozen hemithorax.
How would you manage this patient as a radiologist?
I would check for previous chest radiographs to evaluate the rate of pleural thickening progression. I would communicate the finding of diffuse nodular pleural thickening and pleural volume loss immediately to the referring clinician due to the high suspicion of malignant pleural mesothelioma. I would recommend a contrast-enhanced chest CT for local staging, pleural evaluation, and to check for chest wall invasion. I would also recommend an FDG PET CT for systemic staging, nodal and distant metastatic disease, and to guide biopsy targeting. For definitive histological diagnosis, I would recommend a video-assisted thoracoscopic surgery, ATS, pleural biopsy, the gold standard, which also allows for pleurodesis, or a CT-guided pleural core needle biopsy of the thickest nodular areas if VATS is contraindicated. I would refer the patient urgently to the specialized thoracic oncology service and discuss at the lung cancer MDT.